Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters. Our guest in studio, I think I should say our esteemed erudite dynamic guest in studio tonight is Professor Pravin Manga, who actually does not need an introduction. He's actually been in the field for over 40 years. He's a graduate at Wits University. He did his undergraduate and postgraduate at Wits, and he's a cardiologist. He is the retired head of the Department of Cardiology, but continues to remain a visiting academic and lecturer at Wits University. He acquired fellowships in the UK, and I could go on endlessly speaking about his illustrious career, but I'm not going to continue because of time constraints. However, the topic under discussion will be on rheumatic fever in children and heart diseases. We have 4 segments to this program, and the first 2 segments Professor Manga will be speaking to, and then the next 2 segments will focus on Q&A. As people have questions or comments, it will be entertained. And before we actually hand over to Professor Manga, I would like to start off with a tarbiyah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. We start our discussion with the following verse. Everything good that happens to you, O man, is from God. Everything bad that happens to you is from your own actions. Therefore, disease is defined by the famous pathologist William Boyd as physiology gone wrong. It is our tampering with the natural process that leads to unnatural outcomes. The human body can be compared to some degree with a machine created by man. The fascinating tape recorder has many mechanical and electronic parts, but life does not come to it till an electrical current is passed through. Similarly, in the components of the human body, there are the anatomical parts and fluids, but also the spirit, the soul. As the care of a machine requires keeping it clean, giving it some rest, and passing electricity of proper voltage, and using it carefully and wisely. So are there requirements for the body and of the body as whole. Before we come to the physical care of human body, we also need to look at the spiritual care. The spiritual care involves the acts of worship. The problem is that faith cannot be translated into belief or into prayer, nor can ablution into washing hands, face and feet, and nor the fasting into charity, nor Hajj into pilgrimage to Mecca. They are entities in themselves. Looking at the physical health, one needs to look at nutrition, and God loves His creation so much so that He is concerned even with what we eat and put in our body. From the Quran, open quote, O mankind, eat of what is lawful and good on earth, closed quote. But waste not by excess, for God loves not the wasters. Eat of the good things we have provided for your sustenance, but commit no excess therein, lest my wrath should justify or should justly descend on you, and those on whom descends my wrath do perish indeed. And from the fruits of date palm and grapes you get wholesome drink and nutrition. Behold, in this is a sign for those who are wise. There's also in the hadith quoted the value of exercising in maintaining health, and although we have not found much in the Quran about specific exercise recommendations, the Prophet's life was full of recommendations. The Prophet's life was full of activity, a fast pace even having a race with his wife, Bibi Aisha, may Allah be pleased with her. Most importantly, he used to work with his hands, whether at home, in the kitchen, or with his companions, collecting wood for fire, fighting during wars, but engaging in manual and menial labor. So I think, on ending, what should a patient do when disease is confirmed? Accept it as a will of God and ask Him to remove the affliction. And, open quote, and if God touches thee with affliction, none can remove it but He. If He touches thee with happiness, He has power over all things. Sadaqallahul Azim. And now to our esteemed guest, Professor Pravin Manga, who we are very elated to have here on our program. Welcome to you. And I'm going to open the discussion. We seem to be using the buzzword rheumatic fever, heart disease. It sounds very broad and vague, but perhaps you can start explaining to us and unpacking a little bit around the two concepts.
All right, so firstly, just talking about rheumatic fever and putting in context. Rheumatic fever was not an uncommon condition, I would say 40, 50 years ago. And it's basically occurs in children, less than 8 or 9 years old. They usually present with a sore throat, and it's caused by a bacterium, common bacterium that causes sore throats, Streptococcus. And in most cases, the Streptococcus is very, very sensitive to penicillin treatment. But if not treated, in some children become susceptible to the infection. And for a specific reason for which we still do not exactly understand, why some children's heart valves get affected by this infection. So it appears that the lining of the bacterium becomes an antigen which is similar to the antigens on the heart valves. And so the antibodies then affect, your own antibodies affect the heart valve tissue, which then becomes inflamed. And this is the important part. And in most children, this inflammation settles down spontaneously. But if you get repeated infections, that's when you get damage to the heart valves. And therefore, we'll discuss this a little bit later, is to say, to prevent rheumatic fever and its consequence, if you treat the original infection well, you will not get the consequence of heart disease later on.
So, to the layperson, the non-medical person out there, what would your message be to them? What should they do when the first thing they realize that there's something wrong with the child's throat, or it may be a sore throat?
So I think the first thing they need to do is to take it to the local clinic, and it depends on a particular situation, or your general practitioner, who will then investigate and look at your child, look at the sore throat, and if they find, and maybe we can see a snippet of that one slide that showed what an inflamed sore throat and tonsil may look like. And then that just requires appropriate treatment with an antibiotic. And penicillin, the Streptococcus, which is the bug that affects and causes a sore throat, is very, very sensitive to penicillin. And you can take penicillin in different ways. Most commonly we use tablets, but you can give a single injection of penicillin, and that will work just as well.
But we also find that often in families where there's elders, there's grandparents or aunts, uncles would provide home remedies. And what is your response to that?
Yeah, I think for ordinary flu-like illnesses, home remedies are reasonable. But I think it's, in the modern context, if we want to prevent, and especially a lot of these episodes or attacks of streptococcal sore throats occur in environments like school environments. So if one child gets it, the other child gets it. And as I said, alluded before, if you treat it adequately with antibiotic, if you get attention to it, then you've essentially cured that child of that infection. And the likelihood of that child developing any form of heart disease is very, very remote then.
So what I'm understanding, and I'm appreciating, that parents or caregivers should not treat their children or treat them on their own or at home. They should seek medical attention and rather err on the side of caution than let it.
Correct. I think in young children that's always probably a wiser thing to do. And in many developing countries it's a question of economics. And so therefore rheumatic fever and rheumatic heart disease is almost non-existent in well-to-do countries. So in developed nations, it has almost disappeared. While it's still very, very prevalent in developing nations. Fortunately, I can say in South Africa, the incidence of rheumatic fever and its consequent rheumatic heart disease has declined dramatically since the transition to democracy. So we just see better housing. So essentially, rheumatic fever and rheumatic heart disease is a disease of poverty.
I was going to say that.
It's a disease of overcrowding. It's a disease of poor education. And lastly, it's a disease of lack of access to healthcare.
So interesting what you're saying about the poverty issue and contributing to the rheumatic fever and of course affecting the heart of children and the long-term consequences and implications as a result of that. We'll take an ad break and continue after the ad break.
Good.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. For the viewers that have just tuned in, I would like to take this opportunity to introduce our dynamic guest speaker, Professor Pravin Manga, who was previously the head of cardiology at Wits University and continues to remain a visiting lecturer at Wits University. The topic that we are focusing on tonight is rheumatic fever in children and of course rheumatic heart diseases. And I would like to allow Professor Pravin Manga to continue with that discussion.
So continuing on that discussion, we said you need to get the streptococcal sore throat first as the basis for developing rheumatic fever. And rheumatic fever syndrome where you develop not only fever, you get arthritis, and arthralgia is a term where you get joint pains but without actual inflammation of the joints and without any swelling. And arthritis is where in fact there's swelling as well associated with the pain. There are some other symptoms, signs that we tend to pick up there. And most often we use the medical terminology of Jones criteria in making a diagnosis of rheumatic fever. And I'm not so sure that's that appropriate for the general audience to know but the important point is when the child is ill, has a fever that doesn't remit with therapy, etc., and has had a recent or got an associated sore throat, then the diagnosis must be alerted to the physician that you must consider rheumatic fever. As I said, it's the repeated attacks of this rheumatic fever that leads to rheumatic heart disease. So what happens is essentially the valvular involvement in the heart. So rheumatic fever only affects the valves. It doesn't affect the heart muscle tissue as such. So you get inflammation of the valves. And interestingly, it only largely affects the left-sided valves. We've debated quite often why only the left-sided valves. That means the aortic and the mitral valve, which are the two major valves of the left side of the heart, while it very rarely affects the right-sided valves. And we think it's really related to the pressures. The pressure on our right side of the heart is almost a quarter of the pressure on the left side of the heart. And so we think it's somewhat related to that, but that's not 100% sure that's exactly the reason, but more than likely it plays an important role. Once you get inflammation of the valve, it then swells up, the valve swells up, And for example, the big mitral valve, which is the valve that allows blood to come in, oxygenated blood from the lungs into the left side, that then pumps to the rest of the body. That sometimes starts leaking, and after the process of swelling, it then shrinks as it heals. But once it shrinks, the valve does not close properly any longer.
Okay.
And in fact, two things will happen. The valve becomes incompetent, which is the medical terminology, so the valve is leaking. And that's one of the most common sequelae of rheumatic heart disease, leaking of the mitral valve on the left-hand side. In some instances, with long-standing rheumatic heart disease or rheumatic valvular disease, that valve becomes so fibrosed that it narrows down as well. And then it does not allow blood, the oxygenated blood from the lungs, to flow easily into the ventricle. And so then there's pressure build-up into the left side and into your lungs, and then the patient then presents with significant shortness of breath on effort, not only initially while walking, but even then lying down. Okay,
so what would your advice be to people out there if they've been diagnosed? What is the best intervention or treatment regime to follow?
So firstly, once the diagnosis of rheumatic heart disease is made, I think it's absolutely critical that we do not expose that child to any further attacks of rheumatic fever. There is a theory, and it's not 100% proven, there's some genetic work to support that certain populations, that means certain children, are predisposed genetically to get repeated attacks of rheumatic fever. And therefore we call it secondary prophylaxis. These children need to be put on to antibiotic prophylaxis with penicillin. Some say lifelong, we believe till the age of 40, so that they don't get repeated attacks of rheumatic fever and they don't damage the valves any further. So if you diagnose and pick up rheumatic fever and rheumatic heart disease very early on, I think you will do a huge service to that child, because then the valvular abnormality will be minimal. On the other hand, if the child gets repeated attacks of rheumatic carditis, or in a way is rheumatic inflammation of the valves, then that valve invariably later on is going to need either repair or replacement, which is a major open heart operation.
And is it possible that that open heart surgery may be repeated in the future?
Yes, and certainly in some instances. Most instances we replace only one valve or repair one valve, but in many children both valves on the left side are affected, and sometimes we have to replace both valves. So that becomes a major problem when you now got two artificial valves in the heart with anticoagulation, because you need a blood thinning agent to keep the valves functioning properly.
So obviously then the clotting of the blood has to be monitored. And
yeah, so that becomes a lifelong monitoring process of blood clotting. You need to make sure. So the tablet is called warfarin that we put these patients on, and that needs constant monitoring on a monthly basis as to how thin your blood is being kept to prevent that valve from essentially blocking. And so that's the therapy. But once that valve is kept functional, the patient can then come back to a normal lifestyle.
Okay, and when you say normal, what do you actually mean by normal? Are they able to exert themselves in terms of physical training, regular exercise routine, daily operational activities?
Yeah, with modern cardiological surgical technologies, there are some newer technologies where we don't necessarily need to replace valves. For example, where the valve has narrowed, there's a technology called balloon mitral valvuloplasty. And I've done close to 1,000 of these procedures now. And essentially it's replacing an operation in the past with a percutaneous, that means through the groin technique, where you can blow the valve open the valve with a balloon. And once you've opened that valve, the patient can remain symptom-free for more than 20-25 years before something later may need to be done. So there are new technologies available, and some listeners may be aware that there are now even newer technologies also where we can implant valves without an open heart operation. Now, those are not yet in the mainstream for rheumatic heart disease, but in elderly patients with valve disease, it's becoming a reality. That's still in the infancy in this country, but my view is probably in 20 years' time, valve replacement, the traditional surgical valve replacement, will be a thing of the past.
To be redundant and obsolete.
Yeah.
Awesome. That sounds so encouraging and hopeful.
No, certainly these new technologies are so exciting to try and not only repair but to replace valves without an open heart surgical procedure is tremendous. So you bring the patient in on the day of the procedure and they can be discharged the next day.
Professor Manga, I know you've been more than 40 years in the field, so you obviously would be the expert to respond to this question, is that how, if you look at the incidence of diagnosis made with patients, that have had rheumatic fever with children, how often is it early detected?
Yeah, I think it depends on communities. I think communities that are much better organized, where primary healthcare facilities are available, then early detection is certainly possible. So because I'm the board member of South African Heart Association, and in the early 90s, we realized that rheumatic heart disease was not only a global problem, but it was an African problem. So we got together with a lot of African colleagues, and we came up with the so-called Drakensberg Declaration, which essentially created a program called ASAP, which was related to awareness, surveillance, advocacy, and prevention. And that has been the South African Heart Association's message of promoting ASAP as much as possible to various clinics and communities and health facilities to try and reduce the burden of rheumatic fever and rheumatic heart disease in this country.
So what you're saying is ASAP has certainly created awareness and obviously had some impact, positive impact. And we'll take an ad break and continue after the ad break. But please remember to phone in with your questions and comments. Assalamu alaikum wa rahmatullahi wa barakatuh. Just a reminder to the viewers to please phone in with your questions and comments regarding the topic on rheumatic fever and rheumatic heart disease. We've got Professor Pravin Manga, an expert in the field, and I think the viewers have seen that he has touched on some serious things and sensitive health issues that need to be addressed in children and in adults. During the break, we were talking about lifestyle, Professor Manga, and looking at heart disease, I think the rheumatic heart disease. What is your response to lifestyle, management of your heart disease and lifestyle, the influence it has?
Yeah, so this doesn't really particularly apply to rheumatic heart disease, but I think in the cardiological sense, I think lifestyle management is vitally important. I'm particularly interested in exercise.
Okay, sorry, I'm going to stop you in your tracks. We've got a call on the line. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam.
Sister, please go ahead with your question.
Yes, I had rheumatic fever when I was 25 years old. And I was on penicillin tablets till, Yeah, I was on penicillin tablets till as my age was going. I had that tablets, and sugar, I'm feeling much better.
Okay, so you just want to actually let the viewers
Yes.
hear what Professor Manga said, that if you go on penicillin on the required treatment, it would certainly improve your health.
Yes.
Okay, maybe Professor Manga can also add to that.
Yeah, no, so that's good. I mean, can we ask, did they find a heart defect? Did they find a valve defect with you?
No.
Oh, so that's wonderful. So then, I mean, if there's no valve defect, and I don't know how old are you, but generally...
I'm 63 years old now.
So you're no longer taking penicillin, correct?
No.
Okay, so
No.
that's good. So you've been lucky because you've been taking the penicillin regularly, and
Yes.
you've avoided the repeated attacks that damage the valve. So you avoided significant rheumatic valve disease, and so you've been very, very blessed and lucky that you took the medication correctly.
Yes, correctly. And thanks to God and the doctor who helped me on my treatment.
Okay, thank you, sister. Thank you so much for sharing that with us. Assalamu alaikum.
Wa alaikum.
We have another caller. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello. I'm not getting the caller through. Oh, the call dropped. Okay, we'll continue. You were speaking to lifestyle and you...
Yeah, we were speaking to lifestyle, which doesn't necessarily only applies to rheumatic heart disease, but more to the more common diseases that we see, which is high blood pressure and what we call coronary artery disease, which is now overtaking, in my view, rheumatic heart disease as a major scourge of cardiovascular disease in developing countries. So it's interesting, as these diseases are falling in developed nations, it's rising in developing nations.
Sorry, we've got a caller.
Assalamualaikum.
Walaikum salam. Please go ahead, brother.
Ask Professor Manga is... hello, Professor Manga.
Hello.
Yes, Professor Manga, I want to ask you a question is about the... if you have a genetic problem of cholesterol, that is, you get carried forward from your parents. Now, what actually happens, at what stage should you start examining your cholesterol levels in children, and what sort of treatment would you suggest if they find the cholesterol level is high, and of course the side effects of the statins?
Okay, so you ask a very, very interesting and very relevant question in today's time. So the familial genetic form of hypercholesterolemia is quite prevalent in this country in certain populations, particularly the Afrikaner population. And there you get heart attacks in children, in the teens. But the modern therapies of lowering cholesterol, particularly with statins now and some of the newer agents, has dramatically changed the landscape for these children. But the more common form of high cholesterol is what we call heterozygous hypercholesterolemia, which is what many families and individuals have. And there's no doubt the relationship between cholesterol and ischemic heart disease or coronary artery disease is quite clear, and so there's no real debate as to that relationship. And it's been quite clearly shown by science that if you decrease the bad cholesterol, which is the LDL cholesterol, that your chances of having a heart attack is significantly reduced. So the caller asked the role of statins. In my view, the statins, if I had to vote, and I've said this repeatedly to many, many people and my patients, I would vote it as a drug of the century, because in my career, it has revolutionized cardiology. I think the whole concept of side effects of statins have been markedly overstated. And in fact, it has been overstated worldwide. Why? Because the vitamin industry doesn't like statins. And they've promoted vitamins as an alternative. on the other hand, the science is so compelling. It is so dramatic. And the newer agents, the PCSK9 inhibitors, which are not available in South Africa as yet, they drop LDL cholesterol dramatically. And they've shown that even dropping very low levels to even unbelievably lower levels, you're still buying cardiovascular benefit. So it all tells me, and there are some new evidence to show, that the first time when we get to these low levels, we are beginning to show regression of the plaque that is present in the arteries.
Okay.
And that's the tremendous part. Very first time we're beginning to show regression.
Okay, awesome. I think we've got another caller on the line. Please go ahead.
Hello.
Hi.
Hello.
I had rheumatic fever at a very young age, and then I'm 55 years old now. I just want to know, what are the chances of me contracting it again? I also want to say that I am allergic to penicillin, so I can't take penicillin. So what can I do in order?
Can I ask you, did they give you an alternative antibiotic like erythromycin?
No, I was very young at that time. I think I was between 5 and 10 years old.
Yeah. So
I don't know what treatment I received.
okay, so you probably did receive some antibiotic, and if it wasn't penicillin, you probably received another antibiotic called erythromycin. And there are some other antibiotics that you can sometimes use if you're penicillin allergic, but those are in the minority of individuals. You're now age 55. Your risk of developing rheumatic fever is exceedingly rare at your age, and you don't need antibiotic prophylaxis any longer.
Okay, that's good to hear.
Okay, has that answered your question?
Yes.
Okay.
Yes. Thank you very much.
Pleasure.
Pleasure.
Okay.
Thank you. Bye.
All right. We can continue. We've got, I think, 3 minutes for this segment.
All right, so we were talking about lifestyle, and the gentleman earlier asked about cholesterol, so I've addressed the cholesterol issue. The one thing we can quickly address, and I think there's now also a developing science which is quite compelling, is on the value of exercise, and this really plays into lifestyle, and we see it in every surveillance where communities where lifestyle is not, with regards to exercise and diet, is poor, the prevalence of heart disease is much higher. So where in fact we're seeing developed nations where lifestyle changes are already being made, we're seeing a decline in prevalence of ischemic heart disease. And this has somewhat in relation to do with cholesterol management as well. So the two go hand in hand. And I'm a big advocate for exercise, not only in young, but actually in older people. In fact, in my view, the benefit of exercise in older individuals is much more compelling than in the young. If we look at the evidence, most of the evidence for exercise actually was not in the very young, but in the sort of middle age group. But there's more recent evidence to show that exercise, even in the older age group, is significantly benefit, and not only significantly benefit for the audience to hear for heart disease, but vast benefit for bones, and in fact more recent evidence showing that there's probably a 35% decline in your risk of developing Alzheimer's disease.
Oh, wow. That's something that could certainly encourage everybody.
Absolutely. It should be encouraging to all of us. We don't want to be forgetful when we get older. And so that should be one sort of thing to say, why don't we start exercising now?
So what kind of exercise would you recommend? You said with the elderly, the benefits and the merits. What would you recommend?
So I think there's now more recent, and this is the more recent evidence to show, because we tend to, as a natural physiological process, we lose muscle. And that's part of the reason why we become somewhat less strengthful as we age. But the recent evidence to show that if you do muscle strengthening exercises, not only aerobic, but muscle strengthening. So you do any form of resistance, whether you do it with dumbbells, your own body, or resistance bands. And a lot of patients ask me, but I said, it's not question of putting on muscle. You're essentially decreasing muscle loss, but you're strengthening what you have.
Absolutely.
Not only you're strengthening muscles, but you strengthen your bones as well. So you decrease your fracture risk. You become more stable. All of that. So the benefits in older people is highly significant.
Significant, certainly reassuring to hear that exercise can improve that. And we'll take an ad break and return to the last segment shortly. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters. We are in the last segment, and our guest in studio tonight is Professor Pravin Manga, and I'm sure for the viewers that have been tuned in, have found it very interesting, fascinating, and intrigued by the information and evidence that he's provided to us. Professor Manga, we're at the last segment, and perhaps if you can speak to some of the crucial things and the edited highlights you would like to leave the viewers with in terms of diagnosis, treatment, and prevention.
All right, so our topic was rheumatic fever and rheumatic heart disease. So I think generally most people would take their children in for an examination, even if it's for a flu-like illness. So somewhere along the line, I think in this country at least, we have access to primary health care fairly easily, and they would have been assessed by a health profession, and if there was an issue with their heart, they would have been picked up. We talked about a little bit about sore throats, and that needs to be assessed and managed and treated adequately to prevent any possibility of developing rheumatic fever and subsequent rheumatic heart disease. And as I've just alluded to, in this country, there's a remarkable decline in the prevalence of rheumatic fever and rheumatic heart disease.
I'm going to have to stop you. We've got another caller. Assalamu alaikum. Hello, please go ahead with your question.
Hello. Walaikum salam.
Brother, please go ahead.
I'd like to know, my wife's got rheumatoid arthritis and she's on methotrexate. Is that good? Assalamu alaikum.
Yes.
My wife is got rheumatoid arthritis.
Yes, Professor heard you. If you can switch off your television, and then Professor Manga will respond to you.
All right, so methotrexate is what we call one of those autoimmune disorders, and your wife has been put onto methotrexate, which essentially suppresses the inflammation. It is one of our first-line therapies to keep the inflammation at bay. If we fail with methotrexate, we have second-line therapies that will then to try and suppress the inflammation and subsequent damage to the joints. So methotrexate is routinely used by many rheumatologists now for the early management of rheumatoid arthritis.
Okay, thank you. I think you've answered the question. If we can just continue with the key messages you would like to leave the viewers with, please.
So that's the issue about so just touching back on rheumatic fever and rheumatic heart disease. We've touched on that. As I said, we're certainly seeing a marked decline in the
yes.
prevalence, and it's largely because of improved socio-economic conditions in this country, access to health care, better housing, etc.
And more awareness raising, as you said.
Look, the awareness raising and the surveillance data has made, I think, a significant difference in this country. With regards to the more adult forms of heart disease, the two big ones are hypertension and ischemic heart disease. I think most viewers would know that in South Africa it's a big problem, and we don't have the time to cover it. 1 in 4 South Africans have high blood pressure. But that again, it's your primary care physician can treat that. And again, lifestyle modification is critical. Keep your weight down, exercise regularly, moderate salt intake, and together with medication, you can control any level of blood pressure in my view. if addressed correctly. And then with regards to ischemic heart disease, which now is probably the #1 cardiovascular disease in this country, one of the callers highlighted the issue of cholesterol, which I talked to about. I didn't address as to how young you go. And we don't have the science behind that, unfortunately. But talking privately to many cholesterol experts in the world, most believe that you should be starting young, because apparently young kids in the United States, the Begalusa study showed that teenagers in their 20s, when they died through motor vehicle accidents, they already found disease in their major aortas. And so some of them believe that if there's cholesterol and there's a family history of cholesterol, the cholesterol medications such as statins need to be started at a young age if you're going to prevent the late onset of ischemic heart disease or the atherosclerotic form of heart disease.
Okay.
And then finally we touched on about exercise. Exercise per se will reduce your risk of developing a heart attack by almost 30%. Probably even more in genetically predisposed individuals. We've touched upon, and I think exercise at almost any age is critically important. And I try to emphasize that to my older population patients, that my wife says to me, she's astounded by the 80-year-olds who in fact almost seem to outperform her at gym. And in fact, so that's the message, that exercise should be part and parcel of what we do on a daily basis. Moderation in diet, and taking good care of your blood pressure and
lifestyle
and
approach.
lifestyle is critical.
Indeed. And I think you mentioned there's going to be another Congress coming up soon.
Yeah, so just for the viewers' interest, we have the South African Heart Association. It's the association of all professionals dealing in cardiology matters. We have our annual Congress, and this year's Congress will be at Sun City in October. We have a lot of international...
I think they flighted it on the screen.
We have a lot of international speakers at this meeting, and certainly it's our premier event for the year.
Awesome. Okay, so you've highlighted something which I think has really left an imprint on my mind about the exercise. I think we speak about diet, we speak about lifestyle management, but exercise for the elderly and the benefits that one can derive regardless of what age one is, whether you're 40, 50, 60, and you mentioned 80-year-olds, that it could improve one's health at any phase or stage of one's development. And I think that is something that we all need to take seriously, because obviously you are speaking from a clinical and perspective, but also being in the field for over 40 years, having seen and worked with so many patients, you have seen progress and favorable prognosis.
Yes, it's just talking to that. I mean, in Europe and in America now, it has become now standardized programs of resistance training exercises in old age homes, because the science has clearly shown its remarkable benefit in older individuals. So now resistance training is becoming part and parcel of training in old age homes as well. And so that's nice, and hopefully many old age homes in South Africa will follow the similar example.
So there's hope for everybody, regardless of what age you may be.
Well, we're living much older. I mean, the average
Indeed.
survival in this country is closer to 78. So certainly there's many who live way beyond 70, late 80s, and even 90s.
And it's not just to live to that ripe age, but to live well and to be able to enjoy even up to that age.
Oh yes,
life
absolutely.
to
I
its
mean,
fullest.
enjoyment is a critical part of it, but your enjoyment is so much better if you're healthy.
Absolutely. So your parting shot, your last shot, we've got 2 minutes to go, and we come to the end of the program.
Well, I think because I'm a cardiologist, I mean, I talk about heart matters. I think in all my years, I've come to realize that I think preventative measures make such a major impact on cardiovascular disease, whether it be rheumatic fever, rheumatic heart disease, and that's simple, just monitoring sore throats and treating them adequately. But even when we talk about blood pressure and ischemic heart disease, and even if we touch upon diabetes, those are all diseases of lifestyle. So if we modify our lifestyle, we certainly reduce those burdens significantly, and we will just have much more fruitful and more enjoyable and healthy lives later on as we age. So my message is consider lifestyle changes if you have not already started that, and make it as part and parcel of daily living.
What you're saying, Professor Manga, it's never too late. So
Absolutely, never too late.
Seize the moment, carpe diem.
Yep. I tell all my patients it's never too late.
Indeed, and thank you for that. And I would like to take this opportunity to express our deep gratitude for your, information sharing, and I think the viewers would agree that it has certainly been very enlightening and informative, and we are grateful for this opportunity of having you here today. And on that note, I would like to end with a verse from the Holy Quran. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والأسر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر صدق الله العظيم. Until health matters next time, Assalamu alaikum wa rahmatullahi wa barakatuh.